Okay, thanks everyone. So as people are still coming in, we are going to get started for our special session. We have some exciting speakers to share some of their work. So this special session is called Meeting People Where They Are, Low Barrier and Outreach-Based HIV Care in the Prairies. So we know that innovative HIV care in the Prairie provinces increasingly occurs outside traditional clinic walls. This session is aiming to highlight 3 Prairie-based initiatives: Sanctum Care Group in Saskatchewan, Program to Access Treatment for HIV and Support, or PATHS in Manitoba, and the One Door, One Stop project at Siloam Mission in Manitoba as well. All these programs deliver low-barrier, community-embedded HIV services to individuals who are often not engaged in conventional care. These programs integrate outreach, harm reduction, testing, linkage, and supportive housing or shelter-based care to address complex social and structural determinants of health. And so we'll hear from our 3 groups of panelists to start. They'll each share a little bit about each of their programs, and then we'll have a lot of opportunity for discussion and questions afterwards. So if everyone could hold their questions until the final group has presented, and then we'll open it up. And so to start with, I will bring Caitlin Roberts to the stage.
Good evening, everyone. Thank you so much for having me here today. I'm going to be presenting on CORT, our Community Outreach and Resource Team. Before I get to that, though, I'm just going to give a bit of background on the organization that I represent here today, which is Sanctum Care Group. So Sanctum was started in 2013 with the goal of opening up an HIV hospice and transitional care home. It was kind of during the heart of the epidemic in Saskatchewan. And we were successful in doing that in 2015. And since then, our programs have expanded both locally but also across the province. Our organization is very much focused on outcome-based care. It's really important to us as an organization that we can make tangible differences for the people that we serve. And so with that comes meticulous data collection. So we collect data on admission to all of our programs, discharge, and then follow up, just so that we can be really clear about how our intervention is impacting the people that we serve. And our focus is on patients who typically don't fit the traditional mold, so have complex situations that typically they fall through the cracks of our traditional health and social sectors. All of our programs include integrated wraparound care, and holistic care is at the heart of our organization, and we recognize that you cannot address a health problem if you do not address a housing problem. And so all of our teams are multidisciplinary, integrated, and really focus on the whole person. So why CORT? Saskatchewan right now is currently, much like Winnipeg, struggling in a big way with homelessness, substance use disorder, untreated mental illness, and a lot of mistrust in the traditional healthcare system. We also have a large portion of individuals who at some point were engaged in our healthcare system but have subsequently stopped engaging, and with that are not on ARVs and are AIDS defining. And so, there we go. So sadly, that's why CORT was established. We have a large portion of individuals with CD4s less than 200 who are not on medications, and that is who our CORT team targets. The structure of the CORT team is pretty simple. We have an outreach manager who supports our intensive case management team with coordination of referrals, triage, and engaging with other community supports that will benefit the patients that we work with. And then it's overseen by our physician lead at Westside Community Clinic, along with our infectious disease physicians and our program director. We have intensive case managers who very much, when we say intensive, they are very intensive, seeing patients multiple times a day if necessary. And I transport. That's essentially, they drive a lot, but that's what our patients need in order to get to medical appointments and social appointments. And certainly partnerships with Westside Community Clinic and our ID physicians are critical to the success of this program. So best practice, as I said, we provide intensive case manage and rapid initiation of ARVs. So this, with the court team, it's a bit different than some of our other programs, and that typically we would look to stabilize an individual with housing and other supports prior to starting on ARVs. But given that this particular patient population is really in need of this intervention, we focus on rapid ART initiation while at the same time or simultaneously addressing things like housing, income support, addiction stability, those kinds of things. Patient-centered care is at the heart of everything we do. So again, through that trauma-informed lens, ensuring that our patients are empowered to make decisions about their care and have an active voice in the case planning that we do with them. Multidisciplinary approach, so working with physicians, nurses, social workers, peer support workers to the best advantage for our patients, and then obviously meeting patients where they're at through a harm reduction approach, mitigating risk but respecting autonomy. So this, the court team launched about a year and a half ago. The data I'm presenting on today is on 49 patients that we worked with. A large portion of those patients are Indigenous, 75% homeless or unstably housed, most of them struggling with active substance use disorder, and most of them reported poor or fair mental health at time of admission, and none of them were virally suppressed. Outcomes in terms of substance use disorder, as you can see, even though nothing about our intervention requires a reduction in use, just by nature of having supports available to them, we saw a fairly big drop in substance use in terms of their daily substance use and also in terms of entering into recovery. Financial support, income stabilization, we know is foundational to managing HIV care. So we reduced the number of clients with no income and increased those on CIS into a more appropriate income-assisted program called SED in Saskatchewan. In terms of housing, as you can see, there is a dramatic decrease from admission to discharge in terms of homelessness and a very large increase in terms of stable housing. Medical support stability also increased substantially by 371%. So, once engaged with court, our patients would engage with the healthcare system, primarily our physicians at our primary care clinic, Westside Community Clinic, and the infectious disease physicians. We also incorporated rounds monthly for these patients, so we'd bring together our primary care physicians along with our infectious disease physicians and the court team to discuss these cases individually. Medication adherence, as we all know, is critical for patients with advanced HIV. So these results show that intensive case management can nearly move all clients from inadequate to fully stable medical support. And then again, stable psychosocial support. So as we all know, ensuring that our patients have a multitude of supports so they can manage the symptoms of their disease in community is critical to ongoing stable HIV management in this patient population, and we saw a dramatic increase of 346%. And lastly, outcomes related to medical management of HIV. Pretty impressive results. And I just will add, our interventions are brief. So the vast majority of these patients were on our caseload for about 3 months, but 3 to 6 months, but we saw a pretty dramatic improvement in patients engaging with their HIV physician, ID physician. We had 100% viral suppression and obviously 100% of patients on medications at time of discharge. And that is it for me. Thank you.
And next we have two representatives from the PATHS program, Zachary and Jocelyn.
Do I need a clicker for the slides? Okay, we're going to sit. My name is Zachary Pagan. I'm the Client Engagement Coordinator at the Manitoba HIV program. I support provincial monitoring and strategies for engagement, as well as support PATHS model fidelity, reporting, and scalability. And Jocelyn Bavacqua is a nurse practitioner who is working as a kind of solo PATHS team, as well as supporting our PATHS teams. Anything else you want me to say about it?
Oh, that was good.
Okay, great. Okay, so what is PATHS? So the Program to Access Treatment for HIV and Supports is an outreach and intensive case management program that delivers HIV care and wraparound psychosocial supports for people living with HIV who aren't successfully engaged by traditional HIV care systems. PATHS aims to provide those wraparound psychosocial supports, aims to link to Indigenous-led and culturally safe care, support art, access and adherence, and transition people into meaningful long-term primary care. Currently, PATHS is implemented through two Winnipeg-based pods, and those pods are interdisciplinary teams, and a Brandon-based pod. And the team members typically are a social worker, a nurse, and an outreach worker. The Manitoba HIV program structurally supports referrals, assignments to the caseload, clinical mentorship, standardization, and design fidelity across sites. And PATHS is designed around real barriers to care, so houselessness, unstable housing, substance use, trauma, mental health needs, stigma, and mistrust, structural racism, and lack of culturally safe options, plus service fragmentation and access gaps across Manitoba. So I'll talk a little bit about the model before passing it to Jocelyn for how it actually works. So PATHS is grounded in the concept of psychosocial rehabilitation, so a very recovery-oriented approach that's person-centered, strengths-based, and focused on quality of life and community integration. The model is also guided by the Indigenous Healthcare Quality Framework developed by Ongamazwin Health Services and the Center for Healthcare Innovation. And the goal of using that framework is to continually improve cultural safety and reduce racism in care. And PATHS operations also borrows key features from assertive community treatment, team-based care, in-the-moment services, small caseloads, shared case management, flexibility, and a fixed point of responsibility, which if you were at the lunch session, you would have heard Amanda speak about as well. PATHS comes to people, which works to address power imbalances, kind of the idea being that we're guests in someone's space and we're working alongside their priorities. And how that actually happens is Jocelyn.
Hi, everybody. So how do we work with the most complex cases of care? Well, the answer is quite simple. It's merely relationship building. Because many of the people that we work with have no reason to trust us. It's for good reason that they've come by that honestly, so we need to change that. They've experienced judgment, stigma, racism, and systems that have failed them. So the work first isn't about diagnosis, it isn't about medication, it's just merely about showing up and letting them know that you're going to be a consistent presence that is going to show up without judgment. Often the most important question we can ask at the beginning of every encounter is, what can we do for you today? How can we help? Their priorities always come before my agenda. Because when someone is in survival mode, nothing else works until we can manage their first priorities and their immediate needs. In traditional healthcare, we're trained in the biomedical model. Diagnose, treat, discharge. But that model alone doesn't work for people navigating complex realities. Trauma, substance use, mental illness, poverty, houselessness, amongst the other syndemics that people experience. Care has to meet those realities all at once. It has to be flexible, adaptable, comprehensive, and centered around the person, not just their condition. That means one fixed point of responsibility to coordinate their care. It means practicing shared decision-making, explaining options and risks in plain language, building plans that feel realistic and achievable for the person. And when something doesn't go as planned, when an appointment is missed or a medication isn't picked up, we don't label this as non-compliance. It's merely information for us to get curious. What got in the way? What changed? What may help? Because these moments aren't failures, they're merely clues. And they give us an opportunity to adjust care in a way that actually fits someone's life. This is where the psychosocial model matters. It shifts our focus away from managing problems to co-creating possibilities with the client. It asks us to hold two truths at once, that behaviors can be complex or even harmful, and that person remains worthy of care, dignity, and respect. It means people are always welcome back after a bad day, after disengagement, after starting over. It asks us to acknowledge that all people want to be well, and that care merely has to be acceptable, adaptable, and appropriate to the person. If we want to improve outcomes, we cannot rely on treatment alone. We can have the best medications in the world, but if people can't access them, can't sustain them, or don't feel safe coming to even ask for them, those treatments fail. So we have to think beyond medicine. The biomedical helps keep people alive, but the psychosocial model helps people live, and we need both.
Thanks. So PATHS is, like I mentioned, delivered through interdisciplinary teams that carry small caseloads and do staggered onboarding, because PATHS is a relationship-first modality. So every time they get a new client, they're going to focus on building relationship. If you put 50 clients on a pod all at once, it's going to be really hard to build relationship with all 50. Participants are identified by HIV care teams and public health, and they're triaged based on acuity. So low CD4s, like under 200 or under 14%, or a pregnancy usually means that somebody might connect to PATHS a little bit faster. PATHS does carry a wait list because lots of people in Manitoba where PATHS operates are disengaged or precariously linked with their care. PATHS services are time unlimited, meaning PATHS is going to stay engaged as long as a person needs. If their CD4 gets to a healthy level, if they achieve viral suppression, or if they deliver a baby, PATHS will stay on until that person and the team are ready to move on into primary care or a different supportive model. When we compare, sorry, I forgot to do so much clicking. When we compare people assigned to PATHS versus people on the wait list, 65% of the individuals connected to PATHS and located by PATHS are on treatment, compared to 42% on the wait list, and viral suppression was 45% among those assigned and on treatment, compared to just 18% on the wait list. And among 44 participants who were assigned to PATHS for more than 6 months as of fall 2025, emergency department visits decreased 45.1% after PATHS assignment over the measured periods, suggesting improved stabilization and less reliance on acute care. So, some lessons. We would say that flexibility and shared caseload are essential when people's lives change day to day. The small caseloads and time-unlimited supports match intensity to acuity. Fidelity and coordination across sites matter because we can provide consistent quality and outcomes. And our next steps are working with the Center for Healthcare Innovation and Ongamaswin to develop cultural evaluation I forgot that slide. Cultural safety and quality improvement to be measurable. We're also looking to create pathways with the Indigenous HIV doula program as well. And yeah, that's PATHS. If you want to read more about PATHS, and I'll pass the remote. Yeah, sorry.
And next up, we have Dr. Yoav Keenan from the One Door, One Stop program.
Thank you. I'll talk a bit. How do I get the slides on? I'll talk a bit about the One Door, One Stop initiative, and I'm representing Altogether for Ideas. It's a huge team effort that is basically based in research consortia that is trying to get an initiative to show that this approach could work, and this is a model for intervention. Conflicts of interest are not relevant for this conversation. This is an initiative that involves multiple organizations because as the other speakers have introduced, the complexity of multiple comorbid conditions, endemic conditions, as well as structural and social determinants come into effect and require a multidisciplinary approach. So we have biomedical research, but we also have indigenous leadership, and we are based, this project that I will show you a bit about is at Siloam Mission because of the realization of the housing status and unstable housing as a key component as was presented earlier. We also have planned within the project assessments of some biological parameters, epidemiology, as well as understanding some of the psychosocial components that individuals are facing. And obviously there's a large team there and includes some assessment of the health economics of this intervention. So the idea there is that we can develop something that it may be scalable and cost effective. So the design of the project is that individuals that attend the shelter, in this case Siloam, can sign up to participate in this project. And after they are informed, they sign informed consent because this is a research-driven project, and the individual then can participate in several components of the study. They can choose to opt in or out to any of the components. And we have an initial meeting where we collect the demographics. We have several questionnaires that look at knowledge, attitudes, and practices, empowerment, childhood trauma. Then we collect some clinical information and follow-up questionnaires. And we collect samples that include samples for biomedical specimens, for routine diagnostics, plasma, blood, as well as some respiratory samples, and individuals that agree to participate have additional samples collected. We offer point-of-care testing for HIV and syphilis or HIV alone, and we are in the process of hopefully getting some additional point-of-care or rapid tests with collaboration with the National Microbiology Lab. This is sketch of the schematics of the clinic. So there's a huge sitting area and lots of drop-in services, including meals. That's the busiest part of the place. And then there are waiting areas. And as you can see in that area in the reception, this is the clinic. And at the entrance to the clinic, research member waits for participants, and whoever approaches that are offered an explanation about the project and the opportunity to enroll if they're interested. We can't take everyone that wants to participate because we have some capacity issues, but then we If someone is interested, we tell them when to try to come back. In the clinic, there are several services, including a space for specimen collection. There's a room that offers opioid agonist therapy, is not part of our project. And then we have several rooms where we can have private conversation with individuals. This clinic is operated by volunteers on routines and that offer incredible service, but it's volunteers. And the idea is that we develop this program towards a program that can offer multiple aspects that include prevention, testing, and treatment. So ideally, when we develop this to its full scale, it will be a place where individual can get vaccines for vaccine-preventable diseases, harm reduction, and safer sex supplies, as well as eventually we hope to have HIV PrEP available in this site. It's not currently so. We offer testing, as I mentioned earlier, and all the testing is accompanied by confirmatory testing. So if you get a point of care, you get a blood sample drawn, and we can also monitor for CD4 and viral load and send that to the provincial lab from there. The idea is that there are individuals that don't engage or are not connected with other healthcare, and that's the only place where healthcare system or healthcare opportunity is open for them. And then we offer treatment for STBBI that are diagnosed. We try to connect with opioid agonist therapy, those who are interested, alcohol anti-craving medications, and connect to mental health support. It's a huge team that requires additional resources that we don't currently have there. We are advocating for the presence of a nurse practitioner. We have collaboration with a pharmacy that is on site that is fantastic. We need additional social work and some stable lab, as well as we rely heavily on peer support and navigation. Mental health counseling would be really essential there. And we would like to make it into a regular clinic with primary care, addictions, medicine, and some mental health. This is a busy slide of the principles of STBBI testing and treatment, and we have basically established processes for each STBBI so that we can offer treatment for syphilis, gonorrhea, and chlamydia on site. People who are diagnosed with HIV or have had a previous diagnosis of HIV but are not seeing healthcare. Otherwise, we try to make a plan either with a renewed referral or with providing some of the care on site if they're visitors of the shelter. And for hepatitis C, so far what we've done is refer to partner clinics for treatment. And we have counseling post-testing, and we offer repeated testing. This is unpublished data of the experience so far with the first 106 that were screened, and I'm going to show you some of the data for the first 90 that we have results of, and this is over the span. It started in December, then there were some holidays in between, but this is the volume, and it's dependent on our capacity to encounter people. And we collect the samples that I mentioned earlier. I won't go into those details. And the stats are thanks to the assistance of AI. They look pretty, but they are not really, the numbers are quite striking. So of the people that we tested, nearly 80% have at least one sexually transmitted infection. The most common is hepatitis C, followed by syphilis and HIV. Those rates are really, really high, as you can see in the slide. And if you look at the right side of the slide where it's women, so among women, 86%, so only 14% had no STI. All the rest had at least one STI, and 64% of women had hepatitis C virus infection. And you can see that we identified several new HIV diagnoses, as well as a significant number of individuals who are previously diagnosed with HIV and not linked to other form of stable care. Our proposal is that we can have a wraparound service for people who are experiencing houselessness, that starts, as was mentioned earlier in the presentation of Caitlin from Sanctum. Housing is critical. This is provided already by Siloam Housing Navigation. Then mental health counseling, provision of harm reduction services, testing and management of sexually transmitted infection, but also remembering that those syndemics include additional infections, so wound care and other things that prevent skin and soft tissue infection and endocarditis, provision of dental care. This is currently done by volunteers, and then some support in terms of food and hygiene supplies. So the idea is to provide one door that provides all of those services. And the principle is similar to the principles in the other two presentations that preceded me, and it says that we meet people where they are. It provides one door, one stop in shelters, provides harm reduction, testing and prevention with vaccines, as well as mental health and primary care. Those accompanied by housing support, hopefully can result in improved outcomes. And we are also looking at the reduced hospital and emergency department costs, cost of and quality of life, and long-term savings, because those eventually are things that help to convince our funders. So it's a huge team effort, and we are in debt to the participants. People have trusted us and have shown up and want to participate more than we can accommodate at any given time. Our peer team is fantastic and helps us with all of that, and the research advisory committee that is supporting and ensuring that we're grounded in what people need, and huge list of collaborators that do this different aspects of the biomedical, psychological, economic aspect, and the funders. Thank you.
Okay, so now we'll have some questions for the panelists. I'm going to get us started. I'm wondering, have you had to change anything from your initial conception of the care model as you planned it? And if so, why?
There are several things that we constantly learn from what we do. For example, for me, it was surprising that the POCT, the number of people that are refusing point-of-care testing and prefer to be tested and not see the result immediately. So we have many more people that agree to testing, but not to point-of-care testing. So that changed a bit of what we do. There are constant changes. This is an adaptive process, and we're learning what people want. We also learned, for example, that there is a hierarchy, and if we just wait in the reception area and first come, first served, there's a power dynamic that prevents women from getting in. So we find ways to do that, to ensure that there are days that it's only women. So different strategies that you can only learn by being at the site. It's a dynamic of specific to Siloam. I'm sure if we'll go to another place, it will be some different dynamic. But you can't do it without the advantage is we had Nurse Maya. I don't know if she's here, who's been at the shelter for almost 2 years prior to starting the project. Pointing to what everyone else has already pointed, the relationship building is critical, and knowing how to navigate the system and understanding how it works in reality is You can develop a project, but it won't work if you don't have adaptability and flexibility.
There are likely a lot of clinicians in the room who maybe are interested in kind of non-traditional models of HIV care. And I'm wondering from each of you or any of you if there's something that you wish clinicians knew about this model of care and how it's different from traditional kind of brick and mortar models of care.
Okay. So my background is in social work, so one of the things we hear a lot when we're learning to be social workers is just be curious, have curiosity, compassionate curiosity. Paths has worked with numerous people who, they meet, they engage their participant a few times, and then it turns out that one of the reasons that person wasn't engaging in HIV care is because they couldn't read. And none of their clinicians in the past had ever made note of that or been curious enough to kind of lead to that as a reason why they weren't engaging to care.
I don't think this is earth-shattering, but I think for the patient populations that we work with, I find it fascinating that we've built systems that have all the resources but expect the people with nothing to come to the organizations with everything. And I think for us as an organization, if you understand even in the smallest way the challenges that our population is faced with, even just the amount of steps one has to take in a day to achieve kind of meeting their basic necessities, then you would understand how important it is to bring the resources to those people if you want them to engage in services. And the only way to do that is through building strong relationships and listening to the patients that you serve in terms of what their needs are and what they want. And the good news is that everybody wants to be happy and healthy. It just looks different for everyone in terms of how we get there.
I would say that for me, I agree with all the lessons and basically echo the same comments. But in addition to that, I would say that shelters provide an incredible public health opportunity. This should not be. We're doing it as a research. In an ideal world, this would be where you put a clinic. This would be where you put the resources, where public health is to do, and it's not the current situation. So as much as I think this is a place that would have even if you're cynical and think just in terms of costs, this would be the most cost-effective place to have those services available. But obviously we're talking about people's lives, so this is more important. You would improve outcomes. So between 600 and 800 people visit this shelter every day. So this is where I would put my services.
I have a question for you, Caitlin, to put you on the spot a little bit. So you've shared in this presentation and a previous presentation at the conference some of the amazing programs that Sanctum has in Saskatchewan. And I think a lot of us from Manitoba watching those, you share about those programs, were kind of thinking, oh my gosh, I wish we could get something like that in Manitoba. To mirror the work you guys have done with Sanctum. So I'm wondering if you could speak a little bit to how Sanctum got started in Saskatchewan, or any advice you might have to us in Manitoba wanting to start programs similar to the work you guys are doing.
That's a loaded question. What would I give for advice? Well, I think Sanctum started because there was a desperate need in our community with people who were dying of AIDS who didn't need to, and the need for systems that met those patients where they were at and focused on the social determinants of health. And I think probably Sanctum's key to success is that we have been very good at articulating that you can provide alternative models of care that do better for the patient than the traditional healthcare system. So Sanctum, for example, our HIV hospice and transitional care home, we take patients directly from hospital. So it is an acute care diversion strategy, and we provide much better health outcomes than the hospital ever could, because acute care systems aren't designed to address issues of addictions and homelessness, but you can purpose-build programs that are geared towards this patient population and see better outcomes for the patient, but also better outcomes for taxpayers, because by nature of providing a better service in an alternative setting, you're saving money and lives. And so I don't think it matters what political party you represent. You can't argue with that. And I think that's a strong basis for the work that we do. Our mom-baby programs, and I think it comes back to that integrated model of care. I'll use Port as an example. We were funded as a response to the removal of birth alerts, but what we do is so much more than the prevention of apprehensions. It's a big piece of what we do, but we're also a provincial strategy for congenital syphilis, because how we operate is holistic. So you may have funded us to prevent infant apprehension, but as a part of that, we're also going to make sure that we're improving the health and well-being of both mom and baby by ensuring they're connected to the right services and supports, not just for their health, but for their social outcomes. And we're just finishing up a 4-year project, and the social return on investment it's absurd, actually, in terms of the cost savings. And I think using data and numbers to inform politicians, I think, is the key to at least Sanctum's success in Saskatchewan. And also, if there's any bureaucrats in the room, I apologize, but avoid the middlemen. I've been told no a million times, and the only way I got a yes was going direct to ministers.
Thanks. I'm going to put Zachary and Jocelyn on the spot. A similar question to that we had in the session yesterday to Amanda, also with PATHS. I'm wondering, you guys know that we have such limited resource to fund everything we need to fund, and I'm wondering, with you both kind of deep in the weeds with PATHS, if we had magically some extra resource that we were given that we could use towards PATHS, how would you guys use it?
Like Amanda said, it's a tricky question to answer. I was doing some math before we got up here, and to meet the need for PATHS, the people who've been referred but aren't connected to a PATHS team, we would need 5 additional pods today to meet today's need. And, like I said, it's a time unlimited service because we want people to know that they matter to us even when we reach clinical goals. And so if they have any instability or they haven't achieved their version of rehabilitation, they're going to stay on. And so more pods is what would be great.
I have a question for Yoav about the one-door, one-stop model. Do you think that there's something specific to Siloam Mission and where you guys have positioned that program, that model of care, that is what makes it work? Or do you think it could be adaptable to other shelter-based locations that people are frequenting?
It's also a complex. We tried. All the interest in shelters started when we had a meeting of shelters as public health venue during the pandemic for Manitoba, Saskatchewan, and northwestern Ontario. And each shelter has different circumstances and different infrastructure and different personnel. So everything, we think that you can do a model similar to that in different shelters, but it can't be one model. It needs to be custom made for each place because each one has different services. And specifically the reason for Siloam is the passion and the availability of many of the key services already. So they do the housing. They're incredible, passionate people that work there and are providing the services already to incredible number of people that trust this place and come there. There are, beyond the beds that people stay overnight, people come for additional services, including food, clothing, and some additional supports. Many people have their mailbox there as their most stable thing and most stable address. So it makes sense if you want to reach people that are the most mobile and don't reach healthcare system to be there. So Siloam is unique in that, but it's not the only one. And then if you want to fit the model, you need to custom build it for capacity. Siloam has this incredible soul care clinic with rooms, and currently the model is based mostly on volunteers, incredible people but it's difficult to schedule. So that is a unique advantage, that you have some infrastructure that you can leverage to provide more stable care.
Does anybody in the audience have any questions for our panelists? I think we might have a microphone that can go around. Oh, it seems like I have a question over here.
Sorry to make you run so far. Thank you. Great presentations all the way around. Mark Randall, SafeLink Alberta, if you need introductions of some kind. The two ladies. Yes, thank you. I'm very tired. It's been a very long day. I really wanted to point to one of your slides where you broke down how you got them connected to treatment, got CD4 count as a focus. I would really encourage you to add to the success of those slides and those activities the fact that those people are undetectable and thereby untransmittable. And that's a success of TASP. And if you can sell that to your funders, as well as to the people trying to come into your programming, that's a win-win. That's like a little carrot at the end of the thing. You can be undetectable and no longer transmittable at the end of your journey. So I think that's a big possible win to add to your programming and your service delivery, because I think that's an outcome you don't know. And I'm curious if you look at viral load in that aspect, because you talked a lot about CD4. So great presentation there. And a gentleman at the end, thank you very much. I'm curious about your volunteers. Are they skilled with the cultural competency to provide those services, or are they just general volunteers who volunteer their time and service?
It's not my volunteers. Siloam Mission has clinic that there are physicians that come there. There is an obstetrics gynecology. There is primary care, and people that just are trained and come there because it's their passion, and it's incredible people. It's just they do it as a volunteer with no structure to have it supported longitudinally, and that is problematic when we're talking about managing chronic conditions that are part of our syndemics, and that's what we hope to convince that it is worthwhile investing in a more stable place that can start to look beyond the emergencies and provide some more chronic disease care to prevent the complications, and then do prevention in all of those areas that I've pointed out. Thank you.
Very quick question. Thank you so much. Really it's impressive all the work that you've done. I'm Santiago I'm an infectious disease physician. I work in Kingston General Hospital, Queen's University. I'm the division head for the division of infection disease. So in a way, I represent the traditional way of treating patients. And I must say from my side, it's really frustrating for me. I can talk to and know all about resistant HIV and all those treatments, and it's useless, facing these patients, and they really need people like you that help them really, So we have several organizations in Kingston that do similar work, and from our end, we've been trying to reach out to them and try to get closer to them so that we can learn from them and try to collaborate better. So my question to you was, is there any, have you reached out to the traditional models in your settings? And also if you can expand on commenting about your funding.
Sorry, is the question for anyone?
Yes.
The funding for most of this at the moment is research funding, so it's not the ideal model. We are trying to use the information that research provides to advocate for this to be funded stably. So that's not ideal, and we also work with multidisciplinary teams, and with multiple organizations, and it's a process that you need time investment and relationship building. It doesn't happen overnight. And I don't know how this will turn out, but I think we're on to something that will be successful.
I can say that part of my role is with the Manitoba HIV program is to enhance care across the province in different ways, build capacity with different stakeholders. Much of my job is providing direct care, but in the other time, I'm meeting with other community resources, so like our PACT, our mental health teams, and ACT teams, providing information on HIV care, what's required, trying to build capacity, just basic understandings of what HIV is, because they're providing intensive services already. They can do things like daily medication administration. They can facilitate a lot, but the one piece that's missing is actually physical health care integrated into those teams. So while we haven't, been able to spread this widely across Manitoba, we're also doing some work in the north with some nursing stations and some communities to build some capacity, hopefully over time, to transition some care directly to communities, directly on site. I can't speak to funding.
I'll maybe just from a practical perspective, I think our organization has always integrated with either infectious disease or primary care that treats HIV. And we reach out to the clinicians in our community to see what they're willing to do. It's pretty basic. If you have space, inviting those teams into your space, I think is a real win. The more you can integrate, the better off you are, and vice versa for us. If you don't have room in a clinic, would you come and round at our facilities? And so we have both primary care and infectious disease that round in our transitional care homes, and then we have outreach teams that are based out of clinics so that we can work directly with those physicians. And when I say directly, like we have cell phone numbers to say, hey, can you write a script for this person, or can you see them like in 10 minutes? And that opportunistic care is so critical when you're dealing with patients who are faced with a multitude of barriers. From a funding perspective, I wasn't paid to say this, but I will say this. Organizations like Gilead, for example, have been instrumental for our organization in piloting projects, so providing us with that startup funding so that we can collect the data to take to the government to say, now you need to invest. And that has been, I'd say, a really key piece to some of our more non-traditional models that government maybe doesn't have an appetite for initially, but once you present data, it's pretty hard for them to say no.
Okay, so that brings us to 6 o'clock. So thank you to Caitlin and Jocelyn and Zachary and Yoav for sharing their work today. And thanks all for attending.